Hello everyone, it's Schematic Med, and today we are going to talk about preterm birth prevention algorithm. Preterm labor is regular contractions causing cervical change at less than 37 weeks gestation with intact membranes. The first question we will ask is, did the patient have a prior preterm delivery? If the answer is yes, next question is, did the prior preterm delivery associated with painful contractions? If painful contractions were present, we say that patient had prior preterm labor and the management is to give progesterone, intramuscular or vaginal. If prior preterm delivery was not associated with painful contraction, it means patient has cervical insufficiency and we will do prophylactic cerclage. Now let's go back. This was when the patient had prior preterm delivery. Now what if our patient did not have prior preterm delivery? In this case, during second trimester, we should do transvaginal ultrasound for cervical length measuring, TVUS. If the cervical length is normal, we will continue routine care. If we will find incidental short cervix, which is 2.5 centimeters and less at less than 24 weeks, we will give vaginal progesterone. One more time, incidental short cervix is 2.5 centimeters and less at less than 24 weeks. Once again, for patients with no prior preterm delivery, a transvaginal ultrasound for cervical length measuring is recommended at 16 to 24 weeks of gestation to assess the risks for preterm delivery. And now let's a little bit talk about risk factors. The greatest risk factor for preterm delivery is prior spontaneous preterm delivery, but additional risk factors can include tobacco smoke, multiple gestation, and prior cervical surgery. In particular, removal of the part of the cervix by cold knife colonization for cervical intraepithelial neoplasia can cause cervical shortening and scarring, which decreases cervical tensile strength and increases the risk for preterm labor. Thank you, bye.